Welcome, everyone. Good evening, and welcome to this Doctors for America live stream. My name is Ravi Gupta. I'm on the Drug Affordability National Steering Committee with Doctors for America. I'm an internist and a national clinician scholar at the University of Pennsylvania, and my research focuses on access to healthcare and innovation, particularly medications, as well as drug pricing and FDA regulations. And I'm excited to be your moderator today and very much looking forward to this panel. I think we're going to learn a lot. Our live stream sessions allow us to explore topics that are of interest not only to the 20,000 physicians, medical trainees, and other healthcare professionals in our network, but also with like-minded organizations and the wider public who are involved and impacted by the societal issues our advocates seek to address. We encourage our partner organizations and the public to attend these free events for a chance to hear from engaging speakers on a variety of topics. And so this evening, as with all of our live stream sessions, we have a few ground rules. Number one, there's no such thing as a stupid question. Number two, speaking of questions, please remember to use the Q&A feature. We will address your questions during the second half of our session, and look out for comments in the chat. DFA staff will be sharing helpful links during the session. Number three, please be mindful in your questions and comments that every individual is at a different stage in their education or advocacy, and that this is a first step for some and a continuing education for others, or a continuing education opportunity for others. And we welcome each of you as you are from wherever you are in your advocacy journey and encourage patience and good attentions from all participants. And then finally, number four, we will be live streaming to Facebook Live, which has already begun, and we'll be making a recording and all materials available afterwards. So today's session, as you saw on the title slide, is Undue Influence, Conflicts of Interest Among Physicians and Patient Organizations. Financial conflicts of interest can hurt both physicians and patients by polluting the integrity of science and education, such as through the manipulation of practice guidelines, and also by harming quality of care and worsening public trust in science and medicine. And this latter point is particularly salient today in the middle of a pandemic. Moreover, as the recent approval of aducanumab, a drug approved for treatment of Alzheimer's disease, reminds us, patients may also be harmed when organizations act on industry's behalf instead of patients. So this evening, we are incredibly grateful to our panelists, Dr. Lisa Bero and David Mitchell, to help guide us and offer a discussion to better understand these issues. Lisa Bero is a professor of medicine and public health at the University of Colorado and chief scientist at the Center for Bioethics and Humanities. She is an international leader in research integrity and meta-research who has developed and validated qualitative and quantitative methods for assessing bias in the design, conduct, and dissemination of research on pharmaceuticals, as well as tobacco, food, and chemicals. She is the senior editor, for research integrity for the Cochrane Library, where she is initiating Cochrane's research program on research integrity. We're also joined by David Mitchell, who is a multiple myeloma patient and founder of Patients for Affordable Drugs, the only national patient organization focused exclusively on policies to lower drug prices. So I'd first like to give the floor to Dr. Lisa Bero for her remarks, and then we will go from there.
Great, thank you, Ravi, and thank you so much to the organizers for devoting an hour to this super important topic. So let me just make sure I can get my screen up. Can I have a thumbs up if you can see my screen? All right, great, thanks. So this is my disclosure slide. I just want to point out that I have no conflicts of interest with the pharmaceutical industry or any other commercial sponsors. So just to make sure we're all on the same page, I think we always know this, but it's important to define it. So a conflict of interest that we're talking about here is really a circumstance that creates a risk that a primary interest or judgment will be affected by a secondary interest. So in this case, we're talking about funding from industry, for example, or conflicts of interest with industry, and the primary interest is really appropriate prescription, treatment of patients or appropriate research. So what we're worried about is that conflicts of interest will lead to bias, and bias is a systematic error that leads to a lack of truth in the results. And what's really important in terms of drugs is bias can over or underestimate an effect. So we see bias in terms of overestimating efficacy of drugs, for example, but underestimating the harm of drugs. And they are both equally important. So how do we study this? We study this with meta research. This is a meta pug, Bailey. He's a pug dog wearing a pug suit. He's very cute. This is what I do, which is not nearly so cute. But this is actually a Cochrane review that shows that industry-funded drug trials are about 30% more likely than non-industry funded studies to find a result that favors the sponsor's drug. And so this is looking across a wide variety of different types of drugs, different areas, and we see the same thing for harm. They're also more likely to find favorable results of harm. So this is actually now called funding bias, and it affects the conclusions of research studies that we read. So that's their interpretation. And that's really important to what gets in the media, what patients might have easy access to. But it also affects the statistical significance of the results, likely to be more favorable, and the effect sizes that we see. And this is very, very important for the downstream effects that this research has when it's included in systematic reviews or clinical guidelines like Ravi mentioned. So that's an observation that there's bias in these studies, but we actually know a lot about how that bias is introduced by industry and conflicts of interest. And we know this from looking at basically internal documents that have been submitted to regulatory agencies and comparing those to what's available to the public by interviewing people, and by looking at internal documents from drug companies that have been released in the course of legal cases. And so by looking at all these other sources of information, this is what we know. Industry can affect every single aspect of the research process. So industry sponsors can drive the research agenda and frame the questions so that they're not the priority of public health, for example, but that they're the profitable question. So that's how it affects the research agenda. Industry-funded studies also may use slightly different methods, although they tend to be quite rigorous because they have to meet regulatory requirements. But then this gets interesting. They may be conducted differently behind the scenes. So even if it's a good method, it might not be carried through. And then the studies may not be published in full. This is called selective reporting. So for example, suppressing harm data, and there may be spin on the conclusions. So we have evidence that corporate sponsorship of research influences this whole cycle here. And as I mentioned, this has consequences way beyond the individual research study, because if the question or how the study is conducted or reported, if any of these aspects fall down, then we don't have trustworthy evidence, we can't have unbiased systematic reviews, and this influences our health guidelines. And this is also carried out through the financial ties of guideline committee members, formulary committee members, authors of authoritative reports. And this has been documented as well. And of course, the big consequence is for patients on what gets prescribed. And these internal documents I mentioned previously are a real goldmine as to what's happening behind the scenes. And we've examined a series of documents related to a drug named gabapentin that were released during a court case. And these documents made it very clear that the marketing strategy for drugs had two arms. One was research and one was education of clinicians. So this was using research and having a publication strategy for science, not to gain FDA approval, for example, but to actually disseminate information about unapproved uses of the drugs. And so physicians are affected through this research, and then they're also affected through the education. This is one of my favorite quotes: medical education drives this market. And there was a lot of description about how they wanted to reach the more junior physicians when they could still imprint on their prescribing practices. So research and education as marketing were very successful for this drug gabapentin. The documents had indicators of success, and that was prescribing, right? So more prescribing, more success. And they saw it happen following their campaign, more prescriptions. So I just want to finish off by mentioning, I'm sure many of you are familiar with the US open payments data, and this has also been real new insight into influence on physicians and societies. Australia also has an open payments database where I've spent the last 7 years, and we've learned a lot from these data. We know from this lovely study here that even small payments can influence prescribing. So payments as small as like $12 US if doctors are having 1 day a week with a sponsored meal, we see increases in prescribing, and it's dose related with the interactions. And we know from Australia, who has information on these events, that the interactions are very common. Many events, 608 a week in Australia. Food and drink was at over 90% of these. And, you know, Australia is a much smaller country, but this was a lot of people and a lot of money. And the Australian database shows us this big blue mark here is what they were spending on educational events. And at one point, they no longer had to disclose what they were spending on food and drink. And that eliminated $4.5 million a month. So a lot being spent on food and drink. And I just showed you the data that says this influences prescribing. And I want to show here one thing unique about Australia is we've got payments to consumer groups in this pink bar here. And David's going to talk much more about that, but we've investigated the consumer groups in Australia because we had access to this data and developed some guidance with consumer groups in Australia regarding these relationships that we can talk about more. And this is my last slide, just to say, you know, this all sounds all doom and gloom, but there's actually a lot going on. I hope we can talk about it in the discussion to improve the situation. For example, the British Medical Journal, Ray Moynihan and I with colleagues launched this whole series on creating pathways to independent research and eliminating industry influence on research, and some really concrete ways to do that. So I look forward to the discussion and David's presentation. Thank you.
Thank you, Lisa. That was a really nice overview of the conflicts of interest that permeate, as you say, education, research, which is particularly pertinent to those who work in the healthcare field, doctors, et cetera. Next, I'd like, David, for you to kind of take the floor and give us your remarks.
Great. Thank you, Dr. Gupta. Thank you, Dr. Bero. I will start by declaring our conflicts or lack thereof. We're independent, we're bipartisan, and Patients for Affordable Drugs does not take money from any organizations that profit from the development or distribution of prescription drugs. This is very, very important in our work. Dr. Gupta mentioned I have multiple myeloma. Multiple myeloma is incurable. It is incurable, but it's treatable for some unknown period of time with very expensive drugs. Right now, my oncologists have me on a 4-drug combination that carries a list price of more than $900,000 a year. So almost $1 million a year of drugs are keeping me alive, literally. Now I'm very grateful to have these drugs. But the fact of the matter is, the reason multiple myeloma is incurable is that nothing works forever. And the reason I'm on a 4-drug combination is because the game in multiple myeloma is stretch everything out as far as you can get it. And so as I began to fail on one drug, they upped the dose, upped the frequency, added another drug. I began to fail, up the dose, up the frequency, add a third, etc. When I fail, which I will, on this combination, I will then be refractory to all 3 of the principal classes of drugs that are used to treat multiple myeloma. So innovation in new drug development is very important to me. If I if they don't continue to invent new drugs that are effective and durable, I'm going to die sooner than I hope. And that's not a whine or a complaint. It's just a fact. And I live with that fact. And today's good. You know, the future hopefully holds better options for me. But this journey taught me something very, very important, and that is drugs don't work if people can't afford them. And this increasingly is a problem, not just with oncology drugs, but all drugs, and especially specialty drugs, brand drugs, drugs administered at physician offices and hospitals. And as I was taking this journey as a cancer patient, dependent on very expensive drugs, I realized that there were no patient groups speaking out about the issue of high drug prices. Where were they? I asked myself. And I became even more frustrated as a patient, because the group that's supposed to represent my interests, the International Myeloma Foundation, not only didn't speak out on drug pricing, but when it did, it spoke on behalf of positions held by drug companies and gave information to patients that was misleading. And so I became increasingly frustrated. I had been doing health policy work in Washington for longer than I care to admit. And I was just passing 65 and wondering what I should do with myself. And one morning I woke up and I had an epiphany, and it was, hey, if nobody else is going to try and address drug prices, maybe you're supposed to. So I asked my wife if I could retire, work for free, if we could put in some of our own money. And that led to the creation of Patients for Affordable Drugs. In a direct response to the absence of a legitimate, authentic patient voice that would address the issue of drug prices. Why don't patient groups speak to the issue of drug prices? Well, it turns out that early in 2017, there was a study published in the New England Journal of Medicine that said that 83% of all patient groups in the US with budgets north of $7.5 million take money from drug companies. It has a chilling effect. In late 2016, the New York Times published a story written by a reporter named Katie Thomas, who documented the experience of the National Multiple Sclerosis Society when it tried to speak out on the issue of drug pricing. And the CEO heard from drug company funders who essentially said, and this is all documented in the New York Times, the funders essentially said, you know, it's really hard to be nice to you and to work with you when you talk about us this way. Not so subtle message. I must say that the National Multiple Sclerosis Society remains one of the very few patient organizations in this country that is willing to stand up to the drug companies. And well, they should, because multiple sclerosis drugs have gone up in price without any justification whatsoever by huge amounts, and poses a real barrier to access for people with MS. Now, can I get my slides up? My understanding is y'all are running my slides for me. And all I'm supposed to say is next slide, please. Allison, do we have slides?
I did not receive slides.
Oh, we sent
from you.
Oh dear. Hang on a minute, just a second. Let me see if, okay, I'm just gonna share my screen, I guess.
And that's fine. Yeah, you can share your screen.
I have to figure out how to do that. Just a minute. Wait. So screen share. And let me just share this. And then let me get this up. So can you all see that?
Yes.
Okay, great.
And if,
We, in anticipation of the fight that we are in right now on drug pricing legislation here in Washington, D.C., and that the patient groups, some of them to a greater or lesser degree would be a problem, we prepared a report that was designed to shed light on the influence pharma can exert and does exert over patient groups. We picked a selection kind of at random, although, you know, it was us, so there was subjectivity involved, of 15 groups that I would call legitimate patient groups, big groups. And I'll show you those in a minute. And then we picked 4 groups that the news media had identified as pharma front groups. And many of them, of these 4, make no bones about it. They pretend like they make independent decisions, but they're owned and operated by the drug companies. And then we picked 4 of the so-called charities that are used to help patients who can't afford the co-payments or co-insurance associated with their drugs. And this is what we found. So you can see here, let me move this over a little bit. Just a second, hang on. You can see here, these are groups that are legitimate groups. You know, the Cancer Society, diabetes, heart, lung, arthritis, Juvenile Diabetes Research Foundation, the group that's supposed to represent me, International Myeloma Foundation, etc. And what did we find out? Well, we found out that every single one of them, oh, by the way, there's 300 pages of backup research for everything I'm about to take you through. But every single one of them accepts funding from the drug companies in some amount or another. All but one fails to disclose the amount of contributions they receive from pharma. They do things like, oh, well, you know, these groups gave, these pharmaceutical companies gave 250 to 500,000 or more than 500,000. And so they obscure in a variety of ways how much they're getting. And some don't tell you at all. They just don't put it up. They don't have to. It's not required on their 990s for them to disclose where their money is coming from specifically. In the third column, you can see how many of these groups have board members with financial ties to the industry. And then in the fourth column over to the right, you can see how many share a lobbyist or a lobby firm with a pharmaceutical company. And by the way, these lobbying firms, if they work for a pharmaceutical company, they can't work against a pharmaceutical company. So if they're working for one of these patient groups, it means they're on the same side as the drug companies. And then this final column over to the right is very important because many of these groups will take positions on issues. Like all of them talk about the need to lower out of pocket, and boy, I couldn't agree with that more. Just one of my drugs, an oral drug on Part D, I have to pay under Medicare. Last year, I paid $15,000 out of pocket for that, just that one oral chemo drug. So the notion of lowering out-of-pocket costs is appealing to patients. It's appealing to pharma. Pharma's view is we should just zero out of pocket, and then no one will care how much anything costs, and we can charge whatever we want, and the government or private employers should pay for it. So every single one of these groups failed to support Medicare negotiation in order to lower list prices set by the drug companies. Every one of them. Why? Because pharma opposes Medicare negotiations. that would lower list prices. And this is where, here in this column, you see the policy impact playing out in the fact that these groups will not oppose their funders. And I will specifically highlight one of the findings. This is personal for me. All of the work is, I acknowledge that. But the International Myeloma Foundation, we found out they didn't disclose any of their funding, but they had to release, for some reason, they made public an audited financial statement that their auditors reported that in 2019, 57% of their funding came from just 2 drug companies. So it's easy to see why the International Myeloma Foundation doesn't work on my behalf when drug prices come into play. By the way, since we issued this report, they now disclose their funders in their emails, and they actually, to their credit, acknowledge that Bristol Myers Squibb sponsors their advocacy activities. Now, this is really offensive because it's one thing to take money and use it for patient education, patient support, nurse helplines, that sort of thing. But when a patient group takes money from a drug company to sponsor their advocacy work, it's pretty clear who they're taking care of. It's not me. So that's very unfortunate.
David, sorry to interrupt. Do you mind just maximizing your screen?
I can do that, I think.
Yeah, just like perfect.
There?
Yep, much better. Thank you so much.
Okay. So then I mentioned to you there are these pharma-funded allied groups, astroturf groups, frequently called front groups. They have beautiful names. The Alliance for Patient Access, the Partnership for Safe Medicines, Partnership to Improve Patient Care, Patients Rising, one of my favorites. All of them failed to disclose individual or total pharma contributions they receive. All of them, according to news reports, take money from pharma. 3 of the 4 have been housed in or staffed by public relations firms, lobbyists, or the pharma trade groups themselves, detailing staff to these groups. And of course, all of them have failed to support Medicare negotiation for lower list prices. These groups are just front groups, and they pop up all over the place. They pop up in the states, on state legislation, they pop up at the federal level, and they exist, they're owned and operated by the drug companies. And so they can fool people, and they fool a lot of people. And it's one of the reasons we wanted to release this report, because it's important to highlight that this existed. And then finally, and I'm taking a little too much time, I'm going to wrap up here shortly. There are these charities. The charities are creations of pharma to help make the harm of the copayment invisible, make it go away. And it's the reason these copay coupons are not allowed in Medicare, because they're considered to be illegal kickbacks under law. But they can give money, the drug companies, to these charities to support patients with a given disease. But even there, for example, without earmarking it for a drug, but even there, for example, if you have a drug for multiple myeloma, and you know that you enjoy a 70% market share with that drug, you know that if you give some money to the Patient Access Network to help myeloma patients deal with costs associated with their disease, a lot of that money is going to go to patients taking your drug. And here's why it's even more offensive, because the money comes back to the drug companies. This is a chart from the Washington Post a couple of years ago. It shows how the donations go to the patient charities to cover copays, premiums, et cetera, to pay for drug reimbursement, drug purchase, and then it comes back to the drug companies. So they take a tax deduction for donating to the charity, but then a lot of the money, the lion's share of it, finds its way right back to them. And some people would say, well, David, how could you not want people to have access to this help to pay for these exorbitant co-payments that are associated with drugs like the ones you take? And the reason is because I believe it is wrong for patients to live at the mercy of multinational corporations and have to go beg for help. We should lower drug prices so that drugs are affordable for everybody, which is what happens in other developed countries. These charities, you know, are not permanent. They exist at the discretion of the drug companies who decide whether to give money, how much to give money, what the income threshold is for someone to receive help. It's purely the drug companies running this. It's a scam. In order that they can sell more drugs at higher prices. And they should be outlawed, and we should lower the prices of drugs. But these so-called charities are, again, creatures of the industry designed to support the profit-making goals of the industry. So that's kind of a picture of how we look at pharma's influence over real patient groups, fake patient groups, and these so-called charities, which are really just marketing schemes. Not much different in some ways than buying a sandwich for the doctor. By the way, half of the largest charities in the country are run by drug companies and these groups. So with that, I'm happy to take questions. And now I have to figure out how to make my screen small again. But I assume I can figure that out.
Robbie, can I just say something real quick? Because it's such a good compliment to David's wonderful presentation. And I had to cover a lot in terms of the marketing via research and education and payments to physicians. And what I didn't make clear is that kind of the output of that marketing is to shift people towards prescribing more expensive medicines with less or lower efficacy even, and also increasing the proportion of branded versus generics prescribed. And so all those activities, are going in the same direction.
Correct.
Less affordable drugs.
Yes, I mean, they both seem to, they're both linked quite intricately. David, I just wanted to thank you for your remarks. It's a lot of what you said was quite remarkable, just in terms of kind of the perniciousness of a lot of these conflicts, and not just in terms of ties to the pharmaceutical industry, but one thing that struck me in particular was the fact that some of these patient advocacy organizations share lobbying firms with the pharmaceutical companies, which obviously has a lot of downstream effects, as you were explaining. Before we get into some of the Q&A portion of the evening, I just wanted to encourage everyone to use the Q&A function just to kind of ask questions in the audience so that we will eventually get to them. The next kind of 15, 20 minutes, I'll ask some of the questions and then we'll go to the audience questions. What I'd like to do is kind of start out narrow and then maybe go out, expand in terms of the questions. And so, Lisa, maybe you can start here, but one of the facets of conflict of interest that arises frequently is that, whether it's a patient advocacy organization, whether it's physicians, whether it's anyone in this kind of milieu, they're encouraged or are asked to disclose their conflict of interest. And there seems to be quite a bit of an emphasis on the disclosure. But what can be done beyond the disclosure specifically? Are there other possible mechanisms to limit conflict of interest? What else should we be thinking about beyond just disclosure if we don't have if there aren't other ways to hold individuals?
Yeah, disclosure is necessary but insufficient to really manage conflicts of interest. That's the bottom line. And I'm part of a policy statement that the International Network on Epidemiology just put out on conflicts of interest. And I think that report really sums it up well, in that the other ways to deal with it are, first you have to identify them. And we saw, like, David went to all this work to identify these conflicts. If you have open payments, it's easier, but you have to identify them. Then you should just avoid them. And then you disclose them, make them transparent. And in some cases, when they cannot be avoided, then you need to recuse the conflicted people from involvement in the decision-making or something like that. So you really, avoid, recuse, find out about them. That's all in addition to just disclosure. And we have a lot of evidence, actually, that disclosure doesn't make people less biased in their advice. We have evidence from meta-research. All this meta-research is based on what's disclosed, and it's showing that the research is biased. So it doesn't eliminate bias, and that's what we really want to do, eliminate bias.
Right. David, I wanted to give you a moment to, if you could talk about it from the perspective of the patient advocacy organizations and thinking about going beyond disclosure.
Well, we have worked with folks in Congress. Claire McCaskill, before she left the Senate, had a bill to require drug companies to disclose gifts to patient groups. And that alone would be a help for policymakers, for news media, for patients to know if drug companies are giving amounts and how much to these patient groups, because then you can take that into account. When it's hidden the way it is now, it's difficult for a patient group that gets an email from their disease group urging them to, vote for a piece of legislation or call their member of Congress to gauge, whose interests are being served here. So we'd start happily with disclosure, and we've continued to work with folks in Congress to discuss legislation to require drug companies to disclose. The fact is the patient groups know where their money's coming from. It's in the 990 they give to the Internal Revenue Service. They just don't have to disclose the portion that publicly that has where they're getting their money. So we thought, make the drug companies report, and then there'd be something like the database. Why am I blanking on the name of the doctor database?
Open payments?
Open payments. That we'd have an open payments for drug companies to report donations to patient advocacy organizations. And at least that it would be there so people can weigh that influence.
And I think it's important to have that open payments legislated and mandated, because a lot of countries have this voluntary disclosure. Australia has that, and it's got great data on consumers groups, actually, that we don't have here, but it's not federally regulated. So that's a real key.
Mm-hmm.
Yeah, thank you. So I mean, transparency, I think, is, it sounds like transparency is one of the, I think, first steps to holding whether it's the patient advocacy organizations, whether it's the drug companies or physicians accountable. One kind of question that I wanted to ask is how you both think about how the pharmaceutical industry donations impact physician professional societies. Maybe Lisa, do you want to start?
Yeah, well, there is evidence on pharmaceutical industry support of societies, and I think one of the risky things about that is that many of these societies produce clinical practice guidelines, as you know, and so if the clinical practice guidelines aren't independent, or those pharmaceutical industry ties haven't been disclosed, or they're not using an evidence-based approach, that can produce potentially biased guidelines. And we do have evidence from work that Ray Moynihan and others have done on undisclosed financial ties related to guidelines that come from societies. And I think, David's analogy in relation to the consumer groups, these sponsorship of the physician societies is also important in that they may be silent on certain issues, or they may be vocal on certain issues, and that's in order to, favor their sponsors potentially. So I think there's the guideline risk, but there's also the positions that they may take. And, it's been harder to track down or link, and I'm really impressed, with what David has done to link the positions on Medicare, for example, to the payments from the companies. And so that is a risk.
Yeah, I like to believe that the professional organizations take their responsibility seriously and don't let the contributions they get from drug companies influence their development of practice guidelines or what have you. I will instead, because I sleep better at night if I think that way, I will instead talk about trade associations for physicians. For example, the Community Oncologists Association is not a physician professional organization. It's a trade association for the people who run infusion clinics. And there's also a group like that for rheumatologists who do a lot of infused drugs. And these groups talk like and pretend to be physician organizations whose first, responsibility is to their patients. It's not true. They're trade associations, pure and simple. And I wish the medical community would draw a clearer line there. It's bad enough that ASCO is I'm an oncology patient, so I pay attention to that stuff, but it's bad enough that the American Society for Clinical Oncology runs this, conference that looks like Disney World for drug companies every year. But when they function more like a trade association than a professional organization, it would be good if physicians would help, draw a clear distinction within their profession or within their practice. Do you understand what I mean? Like, we shouldn't confuse those things.
Right. I wanted to kind of go back to one thing, Lisa, that you said, which is about, the guidelines specifically. And I think that also is potentially linked to the high drug prices that both of you were talking about in your remarks. And so I think that's something to think about. I do want to take a kind of a step back and ask some more kind of broader questions about what DFA members or anyone else who cares about these issues can potentially do, and what concrete actions could DFA members take to either rein in or create a safeguard against this undue influence on physician and patient advocacy organizations. So I think that's kind of, much of what we as DFA, as part of DFA or other advocacy organizations are interested in.
Yeah, well, I think there's a lot that can be done. And this is so important because the individual physician can only, go so far. I mean, it's easy to say no free lunch and I won't accept payments and things like that, but we really need organizational change. And, and I've seen examples of this, people who have lobbied their hospitals, for example, to make sure that they no longer have industry-sponsored educational programs. I think in terms of research, institutions are trying to put in more structures to protect any bias creeping in from industry funding. But even if you have a contract, that's still happening. So we really need to, I think, improve those organizational oversight of the research. And interestingly, I think one way to do it is through the ethics committees that have to approve these, like for years, people didn't have to disclose if they were enrolling a patient in a trial, that this trial was funded by the company, whose drug was going to go into their body. And, that's much more common now, but these ethics committees, I think, would have some power to actually regulate more the industry influence on the trial designs, and patients, I would think, would appreciate that. Journals are changing a lot now, and I mean, there's disclosure, but if you look at that BMJ series I noted, there's moves for some journals just to say we're not going to accept and publish industry funded research in certain areas. There's also moves to make sure that the editorial boards of journals don't have industry conflicted people on them, because of course they have a lot to say about what goes in the journals. So, I mean, I can go on and on, but, I think it's really these institutional structures. I've been involved in a number of university committees that are actually starting to oversee the industry academic relations, it's called. And so actually, these committees, they have actually refused industry funding for research because it's just considered too big a risk, actually, of bias. And so that's the kind of oversight we need. And of course, I think lobbying and advocating publicly and working with people in the community to make everyone understand that this is a problem that affects all of us, actually, is really helpful.
David, I wanted to give you kind of a chance to speak to the question as well.
Nope, I think what
Yeah.
Lisa just said, she covered the waterfront pretty well.
Yeah, right. So it's a combination of kind of individual actions that I think we can take, but a lot of this is also a systemic issue that needs to be addressed at a kind of a larger level. We have a couple of questions from the audience. One question is, so Lisa, this may be more for you. A number of continuing medical education courses offered through medical professional societies are often sponsored by pharmaceutical companies. Have there been studies on the impact of these industry-funded events on clinical practice and medical education?
Yes, there's been studies actually looking at some of the content of these events that show it's not balanced in ways that we talked about before. So they may, feature brand drugs, they may feature only pharmacological therapies. There have been links through these industry document studies to show that the industry sponsored CME that's not balanced can actually increase prescribing. I mean, in 2011, there was an Institute of Medicine report on conflicts of interest that was basically recommending against having industry-sponsored CME. And this has changed a bit because now if you have an accredited CME course, there's a lot of restrictions on the industry sponsorship, but there's still other types of, like I showed on that slide, educational events that aren't strictly the official CME, that are still a way of getting this unbalanced information out. So I think, it depends on what kind of CME you're talking about. And I think this is also where it's really valuable to look at how other professionals get their postgraduate education. So you can actually get postgraduate education without these lavish lunches and Disney type things that David was talking about. Other professions actually, like lawyers, pay for their, themselves for their postgraduate education. So I think, the model needs to move away from, industry controlling this postgraduate education of doctors.
Right.
And it is moving a bit, but not far enough at this point.
Yes, thank you. David, I have a question for you from the audience, which is, how are these patient advocacy, this is referring to your presentation, how are these patient advocacy organizations selected for the P4AD report? Some of the largest ones, including the Alzheimer's Association, which accepted a significant amount of pharmaceutical funding from companies and had significant influence on the recent troubling approval of aducanumab, do not seem to be included.
Alzheimer's Association was not included. We looked at the big groups and we tried to say, what is a reasonable sample? And we tried to pick the big diseases and the rare disease groups and a selection. But as I said in my presentation, we kind of did it at random, although I have to say it was just us guys at Patients for Affordable Drugs saying, what would be a good sampling? So it was subjective in that sense. And I actually give the Alzheimer's Association credit because they actually have said straight up the price at $56,000 set for Aduhelm is, quote, simply unacceptable. So they did speak up about that. Now, the Alzheimer's Association is not the only group by far that advocates for new drugs. You know, I sit on the Oncologic Drugs Advisory Committee of the FDA, and the patients who the industry brings to these meetings and the organizational interest represented from patient groups, or up from patient groups, are decidedly tilted to a cure no matter what it costs. And lots of times a cure no matter what the side effects are, no matter how many adverse events are there. So, Alzheimer's Association, where there hasn't been a new drug in like almost 20 years or something before Aduhelm, patients are desperate.
Yes.
But the sad thing is that what they're getting for $56,000 is hope, and hope that's coming with a body of data that indicates that clearing the plaque out of the brain doesn't actually help the progression of Alzheimer's disease. And that's all Aduhelm does. So I just went in a big circle. The point is, we tried to pick what seemed to be a selection that people would look at and would say, yeah, that's a reasonable sampling of the large patient organizations in America. And Alzheimer's might have should have been there. And maybe if we would have picked this year instead of a year and a half ago when we started that research, we would have put it in.
Yes. Yeah, I appreciate that. And David, we have another question for you, which is that, do you think patient advocacy should be publicly funded, that it might help increase or help shape advocacy as a public interest activity?
I think that it should not be funded by drug companies. The fact of the matter is that most all of these organizations, raise money from other sources. They run 5Ks, they have dinners, I get fundraising appeals from cancer groups. And so there are ways to get money that doesn't necessarily have to come from drug companies that could be used to support advocacy. And we aren't saying shut down the funding to patient groups, because many of them use the funding for good purpose: patient education, patient support. There's hotlines advocating for more research into a given condition. Those are all worthwhile things, but that money should not be used to fund advocacy, period. It should be segregated. And the drug company funders should have nothing whatsoever to say about advocacy, and they should be using, the groups themselves should be using funding from other sources to fund their advocacy.
And can I just add that report I mentioned from Australia, that actually the upshot of that was co-produced with consumer groups and the researchers to produce principles for accepting pharmaceutical industry funding under certain conditions. And the optimum would be not to have that, to have the government funding, for example, but there were things like you said, Dave, put the patient first, and don't get involved in advocacy positions, do you use it for education, but that is totally hands off. So that'll be in that packet of info we have available tomorrow, and people might want to look at those principles.
That'd be great. I would like to see those.
Sure, yeah.
Yeah, that's fine. Thank you. So we do have a couple of other questions, but we're also nearing the end of the hour. And so I would like to kind of close this live stream session by thanking both you and Lisa, you and David, for the great conversation. I mean, I've learned quite a bit, and we're here at Doctors for America. We're quite grateful for you that you were able to join us today. Before we close, I did want to share a couple of quick reminders for everyone. This session will be available for viewing later on DFA's YouTube channel. And then we're also asking you to please take 2 minutes to complete our survey so that we can learn more from you about what went well and what sessions you might like to see in the future. The survey link should be in the chat shortly, as well as in a follow-up email that you'll receive tomorrow. And then I encourage everyone to share future Doctors for America events with friends, colleagues, or kind of other like-minded organizations that you know or work with. We would love to also hear your suggestions for topics or speakers that you would like to see featured in the future. And then please remember to follow us on Twitter, LinkedIn, Facebook to stay up to date with all DFA programs, events, and ways to get engaged. And then you can also check out our events page on our website. We have several events coming up, including our upcoming Advocacy Grand Round session on September 9th, which will be on 3 pathways to universal healthcare. So I'd like again to thank our speakers and all the participants in the audience for joining us this evening, and hope to see you all again soon.
Thank you for having me.
so
Lovely to
much.
meet you both.
Yeah, it's great to meet you.
Likewise.